Today, it is a great honor and privilege.
Be in good health means to me to have balance, to be able to be present in every situation.
Black people have the highest rates of HIV in the country. We only make up 5% of the population, 25% of all HIV cases.
By systemic barriers.
I like that question. So you clearly you've seen the TAIBU logo. You know what it looks like.
Yeah.
So you know the two hands that are right next to each
Yes.
other. That's how I knew that this was my space. So again, my grandmother used to always laugh.
C'est des questions que toi aussi tu peux très bien répondre.
Mais c'est moi qui demande les questions aujourd'hui.
Merci beaucoup à Liben. Je pense que la séparation de famille et des familiarités.
First, thank you, Liben. I'm happy to be here. It's always good to have conversations with you.
The Be in Good Health show in honor of Denise Brooks.
And that the people with the highest risk were going to be Black and Indigenous people.
This is a platform dedicated to discussing and advocating for the physical, mental, and social well-being of the Black communities. Greetings. Welcome to our first ever podcast produced by TAIBU Community Health Center, the Be in Good Health show in honor of Denise Brooks. We hope this podcast serves as your source for informative conversation and insights into maintaining and improving the health of Black communities. We strive to educate and empower our listeners by inviting experts, healthcare professionals, community leaders, and community elders to share their knowledge and experiences. Our goal is to amplify these unique conversations around the challenges faced by Black communities in accessing quality health care and providing resources and support to help individuals take charge of their health and well-being. I'm your host, Liben Gabriel-Michael, the CEO of TAIBU Community Health Center. In this episode, we will focus on the topic of Black mental health. As we discussed in our previous episode, anti-Black racism is at the root of the inequities faced by Black communities and often leads to symptoms of mental health issues. And today, I am very excited and privileged to have Dr. Samra Sahlu, who's a psychiatrist who has extensive experience of working with many communities, but particularly the Black communities, and to have a conversation around Black mental health. Thank you for joining us, Dr. Samra Sahlu. I usually call you Samra, so I'm going to do that so that we can continue in our conversation. So thank you for being here.
Thank you for having me. I'm so happy to be here.
So we're talking about mental health, and particularly mental health in the Black communities. If we can start by just setting the context and the tone of our conversation, what is the status of mental health in the Black communities today?
So I think the answer to that question is going to be a bit complex. As we know, it's not just one singular Black community. We have many different communities. We're talking about people who have come from many different countries, cultures, ethnicities, many different religions, and people who have come through many different ways of ending up in Canada historically.
Yeah.
So when we talk about states of Black mental health, I would say there are some points where things are looking good. Prognosis is looking positive. Mm-hmm. The fact that we're here having this conversation today is a sign that we are more open to talking about mental health issues, that we're not scared to have these discussions. And more people are feeling comfortable coming to community events, raising their hand, speaking up, and sharing with others what they've learned. And I'm glad to say, I think in this case, the internet has also helped with a lot of that, with disseminating information and letting people know about different things that are going on. I think places like this, TAIBU, where people can come and gather in ways that are not just clinical, but also, gather with food, gather with music, gather with art, is so important. And programs and institutions like this are continuing to grow, like the one that I'm also a part of called SAPACY, which is the Substance Abuse for African, Canadian, and Caribbean Youth, which is now going to be rebranded to being called Amani. So it's the mental health program within Amani, which is provincial-wide across Ontario, a network where there are social workers, and in some locations, like particularly ours at the Centre for Addiction and Mental Health here in downtown Toronto, where we have psychiatry and nursing staff available as well, to respond within the healthcare setting, traditional healthcare setting, in ways that are welcoming to Black youth and their families. And so when I see things like this growing, to me, it symbolizes that there are positive shifts. But these things came up in response to very major problems, and these problems still persist. So while I can certainly be happy at the things that we have going on with Amani and at TAIBU, at the same time, when we walk into the hospitals, what we see is an overrepresentation of Black people, particularly in involuntary units, particularly in forensic settings, particularly when we go to work in jails. We see more and more people there than what should be if we did the math according to the population. So thinking about why is this happening and why does this continue to happen is something that has been asked by researchers, by families, by people who have gone through it themselves. And I think those kind of questions are how we end up with programs that are more responsive. We see in communities, in Black communities, suicides that happen and are sometimes kept very quiet. We have a lot of stigma around acknowledging that this is actually what happened. Substance use that, again, can carry a lot of shame, and people, for various reasons and for valid reasons, feel fearful about being open about some of the things that are more difficult to talk about. And then these things play into our physical health as well, because it's not as if our brains are disconnected from the rest of our bodies. When we are going through periods of high stress, and then we feel less likely to eat well, less likely to exercise, and then our overall health outcomes are poorer. That's what we see when we look at data from reports that have been made 20 years ago to reports that have been made last year. What we see is that the outcomes are worse for Black communities in Canada. And so there are organizations that work on this. We have so many that we can be grateful for, and the ones that give me hope, to name a few, like Black Health Alliance. There's Black Physicians Association of Ontario. There's Black Physicians of Canada. There is a Black Health Education Collaborative. These are all great organizations that are doing a lot of hard work in collecting data and making sure that data is presented in ways that lead to change in the real world on the ground. And so when I see those things happening, I see, okay, this is a sign of, positive developments, moving towards positive change and better outcomes for overall health. And what's great about this is when we make outcomes better for the Black communities, health outcomes improve for everyone, for all communities. And so I appreciate that this work has to be done in a way that's very specific to get good outcomes, and also acknowledge that when we get good outcomes here, we can get good outcomes everywhere.
So you touched upon stigma, shame, some of the things that I think has an impact on people recognizing, accepting, or acknowledging that they're struggling with certain issues, but more so in terms of accessing services. And we know it's within all cultures, but I don't know if it is more recognized within the black communities. And so with the stigma and the shame and all the other systemic barriers playing a role, what steps can we take in order to address the issue of stigma and shame? And particularly from a psychiatrist perspective, because we also know that some of the stigma is to access psychiatric services for support and help, right? So what can be done, and what can the psychiatry sector do to be able to address the issue of stigma and fear or trust issues?
Okay. So just a small question
Yes.
then, yeah? Okay. So I think first, we have to recognize mental illness in general is a scary concept.
Yes.
There's so much we don't understand about the brain, about how things can change over time, can change very quickly, and not having that information can make anyone feel uncomfortable. So just to begin with, it's a type of condition that's not always so visible. It's not like having a broken leg or certain things that are maybe more easy to understand or digest. So we have to recognize just at baseline, we're already dealing with something that is anxiety provoking. But then we come to, all right, now what are we going to do about it? We have to recognize that the distrust in the system is well earned. Psychiatry has done a very good job of scaring people, of harming people historically, and that is going to be undone by earning trust and doing consistent work that is honest and sincere. And people have a right, to feel all kinds of ways about something that could possibly take away your rights. Yes. Could possibly, make you feel like you're going to be separated from your family, from your friends, from your community. So I think the first thing that we could do as a group is to not be dismissive of those concerns, to acknowledge that reality, to acknowledge that history. If we even have someone getting to the door of getting to the appointment, that's a win. Yeah. If someone's already gotten to the hospital, came to the clinic, they've already overcome so many barriers on the way there that just showing up there is a sign that someone is willing to try and willing to give it a shot. And so I think not being dismissive of what people share with us about their fears, about their concerns is really important, because we need to show that we're on everyone's side, and you don't want to feel like the person that you're going to ask for help is an antagonist to you. So I think being validating and not dismissing concerns is number one. I think we also have to recognize that within health systems, what data shows us is that Black people in Canada are more likely to come to psychiatry through involuntary measures, right? Yeah. Meaning you didn't come to the appointment because you chose to. You might have been brought by police or some other mechanism against your will. Yeah. And so I think also recognizing that there's a big information gap. I think people still aren't sure even what psychiatry is versus what psychology is versus how could I access counseling or therapy. All these different things are very confusing, a bunch of words that do sound the same. Yep. And we haven't done a good job of messaging and clarifying the differences between these things. Oh, someone said, I'd want to see a psychiatrist, but I don't have money for that. Right? But this is covered under, the Canada Health Act. Yeah. You have access to be able to see it through your provincial health insurance. And let's say you were a refugee and you didn't have provincial health insurance. We have other mechanisms to get things covered. So I think within the healthcare system, we've not done a good job of explaining to folks where you can go for help when you need it before it gets to that point where something is at an absolute crisis level. So making sure that people have information about where they can go to get help earlier on. We don't have to wait till things are an absolute emergency before we start looking for ways to get help. And so that means that help actually has to be available when we go asking. And if we go to a place and we ask for help and they say, sorry, 6 months until someone can talk to you, of course that's going to be devastating.
Yeah.
So the systems have to be available, they have to be known, and they have to be responsive. So they have to be there, and by being there and doing good work, I think eventually things turn around. But if we are not available, if we're not accessible, and we continue to let people down, it's going to be really, really hard to build that trust back. And so being responsive and adaptable quickly, I think, is going to be key in this process.
So what you just mentioned reminded me of, if I may say so, the first time we met a few years ago. And you had come to a youth group, the kitchen table talk with art and health, and you were invited as a guest speaker, and it was my first, meeting you, and I said to myself, okay, it's great to see a black psychiatrist, right? You don't see them. You're very rare species out there, I know, and we can talk about that. But what really touched me was that there was a black psychiatrist who were in a group with young people on a weekend, because we have this mentality of a psychiatrist in a hospital or an office where people go, not so much where psychiatrists are coming out. And the reason why, maybe this came to my mind right now as you were speaking was in terms of the stigma. I think the stigma of mental health, we know, as you mentioned, has its own, root, where it's coming from, the health system, how, this Eurocentric view of people, and particularly black people, has shaped how we trust the system or not. And then mental health being something that is not tangible or seen as a broken leg, or even other kind of physical health, creates this, fear, concern, ambiguity around seeking services. And so from a psychiatrist's perspective, is that something that needs to happen more and more? Is that we understand what psychiatry is, we hear it from psychiatrists who look like us? Because I know when we ask people or refer people to see a psychiatrist, that's always the barrier. Like, the psychiatrist is the word that cannot be mentioned. Mm-hmm. So you mentioned about education. What is it that people from trusted community people, reflective, representative psychiatrists can expect? Mm-hmm. Because I'm just like, there are going to be people who are going to see this message and they'll say, what is actually what should you expect from a psychiatrist? So that they're not scared anymore, that there is this something that...
Yeah. So I think it's a good point to explain the difference maybe between what different mental health care professionals are. And so psychiatry, in this case, are medical doctors. They have MDs, they've gone to medical school, oftentimes work in hospitals, and most of the time are a bit more biomedical, using medications, things like this, prescribing as a way to treat mental health conditions. Now, we're also trained in some psychotherapy modalities, but most of the time it's going to be a more medicalized approach. Psychologists are also highly trained specialist professionals, but not always working in hospital settings, not also covered under our healthcare. And then you can also have therapists and counselors who have lots of different education specializations, but also would not be prescribing medications, but have specialized training in different approaches and different kinds of therapies. And you wouldn't need a referral from your family physician to see them. A lot of programs are self-referral, meaning you could look up, send an email, register online, even pick up the phone and call. A lot of places also have drop-in, walk-in services that you could come to on your own that are really, really good options for at least getting an introduction to seeking mental health care. And as you can see, there's a lot of variety and diversity even within this, just like there is going to be variety and diversity within practitioners.
Yeah.
When we talk with people about looking for therapists, you also want to look for goodness of fit.
Yes.
Because they're a person on that side, just like this is a person on this side. And you're allowed to try different things. You're allowed to ask questions, see what works for you, see what doesn't. And so letting people know that they can be empowered to make that decision, I think is really important. So knowing that there could be a wide variety of people on the helping side with lots of different experiences, I think is key. And then knowing that there are different places that you can choose to go to is also important.
So for somebody who would ask and say, I'm not sure if I want to access or see a psychiatrist, it's just a space where they can go, share some of the concerns that they have, the struggles that they have, with appropriate assessment, and get a treatment plan and further recommendations, particularly recommendations to their primary care providers. I think one of the things we want to encourage people is to access these important services in the primary care pathway, rather than wait until things are very, very difficult to manage, and then they are ending up in some of the additional challenges that they go through. It's just an assessment, a consultation. There's nothing to be scared about, and for them to, there's always a choice. When I go to see my doctor, I have a choice. My doctor would say, "This is what's happening. I'm recommending X, Y, and Z." I always have a choice to say yes or no.
Yeah.
So
and I try to let people know, like a lot of the time, I'm giving you a lot of information so that you can make the best decision possible for you. I'm not going to force you to do anything you don't want to do, and we can talk about it. And sometimes people come back and they say, don't be mad at me, don't be mad at me. I stopped this medication because of, XYZ problem. And I'm not going to be mad. I'm not going to be mad. I'm happy that they came back. I'm happy that they told me that there was a problem, so we can do something about it, And it's, I think comforting for people once they have that realization that it's not going to be punitive, that they're not in trouble, because it's scary. And there have been a lot of times when I've gone to pick up patients from waiting rooms, and just when I turn the corner and I say their name and they see me, they already start crying. Just by seeing, oh, I didn't know I was going to get someone that looked like you or someone that acts like you. Or I've also been told I'm a normal person, which I think is a good thing because it's scary. And so just that relief, I think, of having someone not just that looks the same as you, but on a deeper level understands certain things about communities, understands certain things about cultures, and is willing to learn, because we don't know everything. I think that gives people comfort, and I think that's where we get growth.
No, thank you very much. I think this is great, because we don't want people to think, it is tangible. These are people who will sit down and listen to you. These are people who are going to give you options and choices, and there's always a conversation that happens. As you said, it's not punitive, it's not always directive. It is a consultation, it is an engagement. And I know, So definitely, I think this is good for our audience. The other thing I think maybe people usually ask, and this happens in all kind of mental health services, whether it's counseling or psychology or psychotherapy or psychiatry, is, and I think this is based on this Eurocentric way of thinking about health and understanding other cultures and other people, is around the, how to incorporate the person's culture, language, lived experience. In our case, we're talking about Black mental health, and we talk about this Afrocentric way of understanding the world, understanding our health, understanding ourselves. How much is that important in terms of providing mental health services?
Mm-hmm. Well, this is exactly the part where I said we don't know everything. This is probably a great example of this, because we didn't have Afrocentric health training in medical school, right? We have to acknowledge the limitations of our knowledge, and that's part of being a professional is knowing, oh, this is the part where my knowledge ends and I'm going to have to call in someone else. And that's where connections to community is so important. Where are the community spaces that someone can go to access this? Do you have a connection to that organization? Is there someone you can call, email, get connected with, and know that when I send my patient there, that they're going to be in safe hands, that they're going to be welcomed, that they're not going to be judged? And does that organization also know me and trust me enough to know that if they see someone in trouble, that they could call me and know the same thing? That do they know they could pick up and call me and feel that they would be safe and be taken care of?
Yes.
And so that trust has to be mutual and going both ways. And that's how we get things like what happens here in this room here at TAIBU, right? It doesn't necessarily have to be that all psychiatrists need to go and learn additional modalities, but you should know within your community, hey, if you're interested in this, guess what? We have social prescribing here at TAIBU. So I'm going to send you to the social prescriber, and they're going to talk about different ways that you could get connected. And so that knowing where I don't know enough, but I know who I could call to find out more, I think is the first step.
Do you consider, in your practice, the lived experience? How do you? I should reframe the question. How do you work with or acknowledge the lived experience of people who come into your space for consultation?
So technically, it's already built in to our training, and this is the part where, if you know a bit about medical education, where you have room to get in because it's kind of built in a way. So currently, the way that psychiatry is taught is using a biopsychosocial model. And so this was put forth in the late 70s. And the idea is that there are biological factors, psychological factors, and social factors that will contribute to how someone is presenting in front of you. And all psychiatrists, at least in North America, are trained under this model. So within the social category, that's the room for talking about socioeconomics, talking about neighborhoods, talking about lived experiences, talking about what's going on here that's perpetuating this problem and what's going on that's strengthening you and protecting you from this problem getting worse. So within the paradigm that we're already working in, there's already this concept of social factors contributing to someone's current condition. That already exists. Now, the part is, how do we get people to acknowledge certain parts of our social realities that might be harder to talk about, might be a bit more controversial, and then how do we act on these once they've been named? So it already exists. We just have to get better at actually talking about it and actually working on it.
Thank you very much. The other question I have is around spirituality, particularly around Black communities. Spirituality is central to who we are as people, and how that either helps or impedes mental health for Black communities, and how should we be thinking about mental health services in general and spirituality?
So the field of cultural psychiatry often takes into account the role of spirituality. And so when we talk about biological, psychological, and social, they often add another category, which is spiritual. And this category can be different for different people, as unique as we all are. And I think a big part of this part, again, is knowing where community organizations are that we could get connected to, because we're not all going to be well versed in absolutely everything. And so this is the concept of cultural humility, this idea that I don't know everything right now, that's okay, and I'm going to work towards improving my capacity, connecting with others, building those networks so that that capacity can grow. And so that means calling on spiritual care in organizations, within your organizations, knowing how to reach out to them beyond your organization if it's not already built in, and not being afraid also to engage people in having those conversations. So it's kind of, if you notice, there's kind of a theme here of like being open, of being flexible, of being humble, of being curious. And I would say that it would extend to spirituality. Although oftentimes I don't think this is what we're ending up talking about in psychiatric settings, but at least having the door open to asking about how does this impact you? How would you like for it to be going for you? Can I help connect you to anything that you would need? Would be the way to go.
I'm very excited because you mentioned earlier on about this person who saw you and was like, "Oh, you're human," right? So I'm just learning and listening to you is like, this is what support for mental health looks like: the inquiry, the questioning, the opening up, the connection. Right, and I think it's important that people hear this so that they like, you're always, if not afraid, wary of what you don't know, and so listening to you, and particularly because I think it's because you've done quite a lot of work in communities. Even the work that you're doing right now at CAMH with the SAPASI program is in the hospital, but is very community-based, community-oriented, and maybe that's where psychiatry should be located.
Yeah, I oftentimes over the years have had to go out and meet patients in community, whether that be at shelters, at other clinics, various other places. And the nice thing about psychiatry is you don't need a whole lot of stuff a lot of the time when we're working in the community. So as long as I have my laptop and something where I could get an internet connection so that I could write notes, send a prescription. I call it guerrilla psychiatry, where as long as I have my laptop, I can take it and I can do it in most places. So I think there's so much room. And I know even within Toronto, there are teams that are out on their bicycles, riding their bikes to go meet patients because that's the fastest way to get around in certain neighborhoods. And so I think there's lots of room for different ways to engage and different ways to outreach, which I think is cool.
No, definitely. I think it's it less like it addresses the barriers that is there, like going to a hospital. Let alone mental health, just going to a hospital is a huge barrier for so many people. Forget about the practical stuff of, like parking and getting there, transportation and stuff, but this institution is a challenge. So seeing this presented like this, I'm very excited.
Yeah, it's cool, but there's another thing I was thinking about with institutions. Black people are also within these institutions. Hospitals would not be running without Black staff that work in various departments within hospitals across the country.
Wow.
you know? And I think also how people are treated within institutions is very important.
Yes.
Because hospital staff from all levels, from environmental services to lab technicians, nursing, students, everyone that comes through are all witness to what goes on, right? And so this is also a way that stories and narratives are perpetuated in communities because we can see what happens in these institutions. And so there's health of people coming in as patients. There's also the health of people who are already inside institutions. And so when we talk about health, you know, one of my colleagues, Dr. Anya Norm, says we are all patients.
Yes.
You know, we are all patients. And so health, if we're looking at it in a holistic way, within the institution, within people coming in, with their family members who are also witnessing what's going on. These are the things we have to think about when we're talking about building trust from a 360-degree perspective.
I've never thought about institutions this way. I think, thank you. We usually like put ourselves outside of the system, so it's difficult to see that. So I think it's a very, very good reflection. If I could just go back to this higher, bigger kind of a picture, and looking at health in general, how health has been defined, how health has been constructed, is a challenge for Black communities, right? For generations, and how the frameworks are working, and we have to access these. So, and I'm also talking about, you know, what I'm not an expert in psychiatry, as you probably know very well, but there's always this conversation about, you know, the DSM diagnostic manual and how mental health has been created like that, systemically, generationally, all those kind of things. And is there some work, is there some education, is there some awareness, is there some work that we need to do in order to kind of, if I may use the term, decolonize those frameworks? It's another very easygoing question I'm asking.
Yeah. So I think it's approachable on an individual level. What happens in the individual interaction on the one-to-one? What are the values that you're bringing into the clinical space? So I think, first of all, sometimes it can be overwhelming to look at things on a macro level. And so what we do have control over is our micro level interactions. Yeah. If we step back and we look at bigger things like the DSM, these are socially constructed, right? Yes. They're written by people who are experts. And even within these organizations, there are debates. Yeah. I don't know if I ever showed you, actually, with my colleagues from the American Psychiatric Association, we had put together a documentary on Black psychiatrists from the 60s. And at that time, they were within the APA and spoke up about what was going on, about how Black patients were being treated, about how themselves at Black psychiatrists were having needs that were not being met by the current organization. So in 1969, at the big general meeting, they stormed the floor of the meeting and had a big list of demands. And so this was part of a fellowship that I had done with the organization. And so we had cameras like this, and we went around and we found people, and amazingly, you know, we were able to catch interviews of some of these elders who had, you know, even within recent years past, since we had these conversations. And so to sit with them and hear what was going on in the 60s, in the 70s, what kind of work you were doing to advocate at that time, and how, you know, that advocacy is still going on now and still needed now, but it does happen. And that part, I think, is very inspiring to hear that, you know, we didn't come up with this idea. It's not a brand new struggle. Yes. It's a struggle that's been going on for a very, very long time. And what's beautiful about the fruits of that struggle is that they've blossomed to include other groups And what this led to, at least some of those actions led to, is more specific work that is more inclusive of various groups, gender diversity, sexual orientation.
Yes.
Many ethnic groups have voices heard more so now than in the past because of those Black psychiatrists who spoke up and stood up. And so I think that's pretty powerful. And I think knowing that this happened, within the institution, and sometimes even outside. Sometimes people will say, that's enough, you know what, we're going to go make our own organization. That happens too, and that's great.
Yeah.
There are many different avenues to affect change. And I think making sure that this is on the record and that people know about these histories is so important.
So you're going to share the link of the documentary?
Yeah, for sure.
And then we're going to connect it to our podcast,
absolutely. Yeah.
so that people can have access to that, because I think these are the information that will create awareness among our communities to say there is progress, we're moving forward, we're not starting afresh, and also as an education and information. So thank you for doing that documentary.
Yeah, and thank you to the huge team.
Yeah,
that,
I know. That worked
we
with
always
you.
watch things and
Yeah.
then recognize that there's 10 more big groups of people behind it. Yeah.
Great, thank you. As we are kind of wrapping up our conversation for now, I wanted to ask maybe a personal question, one or two. What personal values or principles guide your work in this mental health field?
Mm-hmm. I think, firstly, I always think about how that could be me. This could very easily be me. If you want to get philosophical, the fact that I'm even here right now, how did all these cells align and work in this way? I ended up being born, but then on a bigger picture, okay, how did I end up here? My parents fled Ethiopia, went to Sudan, came to Canada. What are the odds that I would end up living where I'm living and then live the life that I've lived? But then also, what are the odds that I wasn't in the car accident that might have just happened last night? Do you know what I mean?
Yeah.
And knowing that all of us, I think, are probably a lot closer than we think to being in a place where we might need that kind of help, where we might need help. And there may be times in life where we don't need it, and there may be times in life where we do need it, and that's okay. We've all been at various stages of needing supports. Yeah. And I think recognizing that we are not impervious, that we are not invincible, I think keeps us humble, keeps me humble anyways. And also recognizing I don't know everything. And so if I don't know, I will say it, and I will also commit to trying to find an answer, or at least directing, or at least giving advice about where we could look to find some answers. So I think again, it's that value of humility about all kinds of knowledge, but also about recognizing that it's a lot more than just me that led to me being here at this moment. And same goes for the person who's sitting on the other side.
Yes.
Yeah.
Thank you. And one of the things that, probably also my own personal reflection is it is a challenging space to be able to provide this kind of support on various levels, I think. Even if it's on a personal level, as you said, could be challenging, stressful. How do you keep hopeful and pushing ahead when through this work? It's not an easy kind of work. I would it's not like you're seeing clients, you're doing whatever you're doing is prescription, and you do that, and then it has a lot of things that you put, energy that you put in
carry
there.
with you.
Yes.
Yeah. So for me, the same thing where if I couldn't talk to elders in person, I could read their books. I could read all kinds of writers, all kinds of artists through all periods of time who are grappling with these human questions. And then being very intentional about seeking out joy is so, so vital. And so, for example, 2 days ago, I was in a banya. Do you know what a banya is? So this is Eastern European practice of going into hot saunas and then cold water and rotating and things like this. But there's also tea rooms, and you can socialize and be with people, and going with friends, you know, as a practice. And then the week before, NIA Art Center, which is a Black Art Center, had a Black Art Fair, and being very intentional about, okay, as much as I'm in these spaces where I'm seeing a lot of human suffering, I'm also being very intentional about being in spaces where there is joy and expression and things like that. So going to art fairs, going to things like events in the ballroom community. Toronto Kiki Ballroom Alliance does great work in the queer community, and seeing people be happy and expressing Blackness in all its various forms, I think is the antidote to a lot of what we face on the job. And I couldn't do the work without that balance.
I receive. I receive. My final question to you, Samra, and thank you very much. I think self-care is something very important, but I think more than self-care is being intentional and pursuing something that you enjoy and, you know, lifts you up. So thank you for that reflection.
Yeah, and it's like the saying goes, right? You want to go far, you go together. And so I don't do it alone. It's about finding people who are like-minded, saying, this was a tough day for me. Can we go, you know, hang out, talk about it, do something, have tea, you know. It's about that reaching out. And that's a thing I can't prescribe. You know, I often say to people, I wish I had a pill for this. I wish I had a pill that could give you that healthy friend group. I wish I had a pill that could give you the healthy family dynamics that you're looking for, but I don't have that. And so what we can do is at least be very intentional about the social engagements and interactions that we can change. Yeah.
Very powerful, very powerful. My final question. What does be in good health mean to you?
Mm-hmm. So I think being in good health has to be more than just the absence of ill health. I think it's also beyond not having lab values that are in the red or having physical symptoms of pain. There also has to be elements of feeling fulfilled, like on a deeper level. Feeling fulfilled as an individual, but also feeling fulfilled in connectedness socially, however that might look for someone. And so good health is not just, you know, I'm not sick right now, so things are okay. Okay. And what about all the other categories of life? What about all these other facets? Are we fulfilled there? Are we nourished? And you know, thinking about things, I think like that way makes it a bit more complicated, but I think more honest when we think about like what matters to us in terms of living a good life.
Thank you very much, Samra. Very, very enjoyed this conversation. Thank you for your time. Thank you for the work that you do, both in your sector, in the community. Thank you for how you do your work. I think that's also very important. And I think the audience would have seen that and heard that, that you know, there is passion, there is intentionality, there's care in how you do your work. So on behalf of the audiences and on behalf of TAIBU, really, I would really like to thank you for the engagement conversation that we had today. So this will conclude our conversation.
Well, hold on. I need to say thank you to you too.
Oh, okay.
Come on.
Okay.
Come on.
All right.
I don't think we could do this kind of work if we didn't have people setting up these spaces and supporting us to actually make it happen. And you have done that for so many years, for so many people. And I know I wouldn't be sitting in this spot without your efforts. So thank you to you, and also to all the people that came before us and all the people that we weren't able to name in our conversation today, doing a lot of hard work. So thanks all around.
Thank you very much, Samra. Thank you. So this would conclude my conversation with Dr. Samra Sahlu. I'm 100% sure that you've enjoyed the conversation. A lot of insight, a lot of reflection, a lot of awareness. Like, you know, psychiatrists are human beings, so like this is great. And then we'll transition and talk to Racquel Hamlet, who is the director of Toronto Community Crisis Service and Wellness here at TAIBU Community Health Center, and continue the conversation around Black mental health. Thank you. Greetings. I'm here with Racquel Hamlet. Very, very pleased to be in the space with Racquel for various reasons. I won't say much, but I'm sure it will come through the conversation that we're having. Welcome, Racquel. It's always a great pleasure to be in your presence. I have a few questions I would like to check in with you and have a conversation around mental health. I know mental health is your passion. In the Canadian context, the City of Toronto, for example, has published a review on the impact of anti-Black racism and mental health. And its review noted that the experiences can lead to or add existing mental health issues such as depression and anxiety. For Black communities, these and other mental health illnesses are often overlooked and have increased rates of misdiagnosis, undertreatment, and failure to diagnose. Mental health issues can also exacerbate the risk and harm of other illnesses for which Black communities already face increased risk, like hypertension, stroke, and heart disease. And there are other statistics that we can claim, that we can mention here. But before we go into service provision, mental health, and all kinds of stuff, you've been in the mental health field for a very long time, at least as far as I know. Can you share from your perspective what the mental health for Black communities is right now? What does it look like?
I think right now we're at a crucial point where Black people are aware a little bit more in terms of mental health. Although the stigma is there, we're a lot more aware. We're becoming more open to actually talk about some of these things. But at the same time, there's still quite a few of us who are not there yet. You know, I think we're kind of definitely in the middle. Maybe let's say we're 50-50, where some are very much out there and wanting to get the help, looking for services, where others are still struggling in silence, you know, due to the cultural context, due to, you know, just personally not feeling like they can actually be honest about the way they feel. So I definitely think we have a lot more work to do for Blacks in our community when it comes to mental health.
And how does anti-Black racism really manifest in mental health care systems? And how does it affect the Black communities for them to access support?
I think, you know, there's been a big push on, you know, EDI and DEI. So, you know, all that diversity, equity, inclusion, you know, it's the buzzword. And I've heard people say it's the modern day affirmative action in terms of it's something that we need to do. It's a tick box. So I think that it's being made more common in terms of we have to do certain things so that anti-Black racism is present in our work, making sure we're working from that framework. But I think some of it is being lost in terms of how services are actually being delivered when we're looking at the larger systems. So systems like, you know, the hospital, you know, child welfare, the larger systems, they're still kind of in that tick box place. They're working towards getting there, but it's a lot of work to be done in terms of how they govern, you know, certain things, the principles that they work from, the way they do the work, a lot of work to be done there still. I think when you look at more grassroots organizations that understand and they're built on anti-Black racism, like TAIBU, you know, you start seeing it everywhere. Where anti-Black racism is, you know, it's in all of our trainings, it's in our it's in everything. And so I think when you're looking for, does anti-Black racism show up in the system? I think it's showing up in grassroots places. It's showing up in community initiatives. But again, more work to be done when it comes to, the hospitals, the larger systems, to really understand, Blackness in and of itself before we even get to teaching them anti-Black racism.
And so those spaces, the healthcare system, for example, or the education system, for example, or the child welfare system, for example, what are the barriers there that do not promote the mental wellness and well-being of Black communities?
I think a lot of the barriers are the access. So let's say if we talk about child welfare, when, a child is taken already from the family, that trust is already broken, right? So families don't want to come, to that child welfare place to do a visit. They're already feeling defeated. They're feeling broken. It's not something they want to participate in, but it's more so it's something they have to participate in because they want to see their children. And I think, they'll put an access visit on, I don't know, a Friday at 10 in the morning. If you have a job, you can't go to that access visit. And it shows to the child welfare, oh, this mom is non-compliant. She doesn't want to come and see your child because she's not showing up for access visits. When really, mom can't come because she's employed. And if she doesn't work, she doesn't get paid. And maybe she has other children to take care of, or she's trying to maintain a roof over her head so she can get that child back. I think the flexibility is just not there. They need to meet certain criteria. There's so many things in terms of access. Could mean so many things. Right. And I just don't think they do a good enough job at making it accessible to everybody.
Right. You have been with TAIBU for a very long time, and most of the time that you have been with TAIBU, and we'll come to where you are now.
Right, okay.
But, you were the only social worker at TAIBU.
Yes.
What kind of challenges were you seeing in terms of clients presenting? Some may not be the traditional mental health that we think about. What kind of issues were presenting at the time?
So at the time when I was doing it, there was an influx of refugees from West Africa, South Africa at the time. And I was getting a lot of them in regard to traumas that they were fleeing from, war in certain countries. So that was one of the biggest things in terms of just getting them to trust. So PTSD was huge at the time when I was doing it. I think, one of the hardest things for most of them was that, they're displaced already. So a brand new country, they don't know where to go to access anything. And a lot of the people don't look like them. Right? A lot of the people don't speak their native language either. The way in which, again, you access services is very different. And becoming as a refugee, they have no status, no paperwork, no anything. So if you weren't coming to a place like TAIBU, they couldn't get a lot. So when I was trying to advocate for a refugee, it was, well, do they have a health card? So all of those pieces that really do, as a Canadian, we don't think about it. We just go somewhere, show our health card, and we keep moving. When you come here as a refugee, there's certain things that are not available to you. Food banks, some food banks needed to see a health card or a passport or something. And so a lot of my clients couldn't even access food. So, simple things that, that we, maybe take for granted, those are the difficulties that clients were having. So, I mean, if you can't eat, you don't have anywhere to live, and you technically don't really exist in a country because you don't have paperwork, that's an entirely different level of stress and, and mental anguish that people are going through.
Very true, very true, very true. So we're coming to 2020. We witnessed yet another avoidable and unjust death, that of the young Black Indigenous woman, Regis Paquette. And that was following what happened with George Floyd. We were in the middle of a world pandemic. All that kind of happened. And out of that, was born the Toronto Community Crisis Response. When it comes to TAIBU taking the lead around Toronto Community Crisis Response, there was, we were thinking of doing something different. It's a community response, but something different. How, what role does cultural specific or culturally affirming or culturally appropriate care play in supporting people with mental health crisis or mental health support?
Well, I think when we talk about the Toronto Community Crisis Service, from the day we started hiring, it was very much about being intentional. We don't just want to put bodies in a role. We don't just want to fill a space. It was make sure it's the right person for the role. And when we're looking at right person, we're looking at more than just what's on the resume. You know, do they have clinical skills? We were looking at the entire picture. So when it came to it, you know, myself and you know, other people that did the interviews, we were looking at, is this person somebody that has a heart for community? Do they have a passion for community? Because again, it wasn't a, you know, what's the pay like? That's not what we were looking for. We really wanted people that were passionate about the work. And I think when TAIBU was doing their hiring, we're always looking for people that understand our community, that want to give back to their own community, that really have a vested interest. So I think that's what made the pilot at the time very different from everywhere else, because, you know, of course they set timelines and we didn't quite, we kind of sort of made it. We were supposed to launch a particular day. We asked for a little more time because I needed to make sure the team we had was the right team, right? I needed to make sure we had diversity in language, in gender, in culture, in skills, in life experience, right? We had to make sure that every box was filled. It wasn't just about one thing. And I think that's what made our team unique next to the others.
Right. And also, I think in terms of how the service philosophy and the service delivery is also made, reflects who we're serving and why we're doing this work, right? And can you also talk about how the program is also incorporating trauma-informed care? And why is that important?
Yeah, I think, you know, at the end of the day, when you call a crisis line, you're literally meeting people on the worst day of their life, right? Maybe everything was okay the day before, weeks before, months before. When somebody makes the attempt to pick up the phone and ask for help, they are in dire need. And I think for us, it's really about making sure that, you know, we remember that when people are calling, they probably have experienced some level of trauma, whether it was in that moment, whether it was 20 years ago. It doesn't matter when it happened, but trauma is very much real and shows up in crisis in many different ways. You know, how we do in terms of coming from a trauma-informed place is approaching each case as, you know, person-centered. So we never approach the same case in the same way twice, right? So for us, trauma-informed is understanding where the person is, meeting them where they are, and trying to work with them to go with us together, right? We don't want people to feel like, you know, okay, you've experienced some trauma, we're coming to see you, here's a pamphlet, here's some resources, call a number, we'll check it back in with you, you know, in a couple of weeks. Every time we go, it's always about, let's build some rapport with you. Let's talk to you and really understand where you're at today. You don't necessarily have to talk about the trauma, but we understand that trauma is there. So our trauma-informed approach from what I would say is understanding where somebody is and what they need and trying to walk with them, and not just, you know, giving them resources and sending them on their way, but trying to make sure that, you know, we're taking all the elements into consideration, and just making sure that they're not doing it alone.
And do you think, you know, usually, I mean, for me, sometimes terminologies and words, I always think about those things. So trauma-informed care is a buzzword now. Everybody talks about it. And, you know, maybe when we think about trauma, is it just the usual ways of, okay, maybe there's a childhood trauma, there's the family trauma. We talked about refugees. There is a trauma around civil war and things that has happened. Do you think racism is a form of a trauma?
Absolutely.
And particularly anti-Black racism?
Absolutely, 110%. Because there are people that are afraid to call a service because they've experienced racism from calling before. And that has been some of the reticence for people to call 211, because to them, they just don't know what they're going to get on the other end. They don't know if they're going to get somebody who understands what it means to be Black. So I think when our team goes up, when we show up, and we show up Black, you know, clients are immediately, you know, a lot of their fears are calmed in that moment, because they know the person showing up, I know this person knows what it feels like to even just walk into a store and have somebody follow you because they assume that you're going to steal. So we already have that understanding when we get there, and you see it calm people. As soon as they look at you and we get out of that van, they breathe a little bit of a sigh of relief. I've seen it, you know, I've experienced it myself. It makes a huge difference.
Right.
Huge.
Right. So continuing the conversation around the TCCS, the Toronto Community Crisis Service, there was a report recently that showed that, you know, 78% of calls were diverted from police department or police interventions. there was a 95% satisfaction rate for people who have registered with the service. So many positive things that have come out of this initiative. Is TCCS the complete answer to what we're having in the community in terms of mental health crisis or mental health well-being? Or are there other things that need to be part of a TCCS or a TCCS kind of a service?
Right. I mean, I don't think it's the entire answer. I think it's a great start, right? I think it's a great starting point for a lot of room for expansion, right? A lot of room for having other programs that are similar to it continue to pop up throughout the city, right? And to be honest, if they could all be done like TAIBU, I think we'd be in better shape. Just in terms of how intentional the service is. Like I said, to watch not just the crisis workers when they go out initially, but post-crisis case managers. When they're trying to call somebody, they can't get them, people aren't answering their phone. There is sometimes, a frustration of, we really want to help, but we can't reach them. And sometimes it's, their phone got cut. They're transient, they don't have a place to live. They're kind of just hanging out on the side of the road. Case managers will go, they'll ask an MCT, can you help me? They will go and find a mobile crisis worker to take them to the corner, wherever the person is, and do an intake on the corner, right? And I think that's what makes it different for us, is that we're not, saying, you have to come to the office for the intake, you've got to do certain things. We're trying to make it as barrier-free as possible. So I think that's a big part of how it works.
And then, I mean, in your experience, what other challenges come with going to a person and, responding to a call of, like I'm thinking about housing, I'm thinking about, income, all the other social determinants of health. Is that also a plan to consider how that is done? And is that what the TCCS does? How do you manage a person who's in the streets? So we do have safe beds and crisis beds attached to the program. So we have two beds that are usually a 3-ish day stay, but we tend to extend it just because we all know housing is a problem. There's nowhere for people to go. So 3 days is a really fast turnaround. Central intake is supposed to then find them a bed for a little bit longer. Sometimes they do, sometimes they don't. We have a 30-day crisis bed. So for other people that, they're really vested in finding a spot, need a case manager, just need a little bit more support, we'd put them in the crisis bed. So we have some resources, but it's not enough. It's not enough. Very often we're meeting clients and we can't actually do anything for them, which is the hard part. So we may find somebody who needs shelter, but all of our shelter beds are full. The shelters across town are full. And worse if it's a family, because sometimes we actually have to split people up because some shelters are for men only, some are women and children only. So if it's a family, it makes it very complex. And that in and of itself can be a trauma, right? So we're also mindful of that. You see a family that's unhoused, but would it be traumatic for us to separate them for the sake of housing? Sometimes, yes. So sometimes we're trying to make those decisions in the moment. I think definitely probably, not being able to help clients with certain things is probably the hardest part of what we do. But, all a part of what we do. So essentially what you're saying is, when we're talking about mental health, it's not just mental health.
No.
It's a complex space to navigate. And as much as the TCCS program has tried to incorporate housing, incorporate case management, I believe you've also incorporated psychiatry assessment and stuff like that. So it has to kind of be
a wraparound. It has to be a wraparound support for sure.
And so, what can we do in order to kind of scale up this kind of things that we do? I think. We do some things here at TAIBU, but if we are going to affect change or systems change, how is it possible to scale this up at a higher level, at the system level?
So are you asking me dream if I'm dreaming and I have all the money? Okay.
Yes.
Please dream. So if I'm dreaming, for me to be able to have a Toronto Community Crisis Service in every community health center across the GTA, attached to hospitals, attached to wherever we need to be, because right now there aren't enough of us, right? We cover all of Scarborough. It's just us, right? There's still pockets of other parts of town. Oakville is not covered, Peel is not covered, and there are are, people of color everywhere, right? So we're suffering in other places where TCCS doesn't exist yet. So for me, it would really be about scaling it across the GTA, across some of those, more remote places that we're not in right now, and just making sure that we are fully staffed and it's a wraparound service. So it's not just going out to crisis and post-crisis case management, but you maybe do have, primary healthcare attached in some way, almost like an ACT team attached to us. That would make us a powerhouse. If we had an ACT team attached to us with, NP, social work, we'd be set.
Great. Thank you. So let me ask you maybe a personal question.
Oh
now,
boy.
if you may allow me to do that.
Okay.
What personal values or principles guide your work in supporting communities around Black mental health?
That's a good question. So I think it's a number of things in terms of values for me. I think growing up, we were always taught if you can help somebody along the way, then you've lived your life purpose. If you've done what you're supposed to do. My grandmother always used to sing this song, then my living is not in vain. And that's the entire song is based on that. So if you can help somebody along the way, then you've done what you're supposed to do as, as a good citizen, as a good person. So that song stays in the back of my head all the time. And I think about it in terms of the work that we've done here at TAIBU from my day one until now. We've helped a lot of people. And I think a lot of those people have then turned around and helped other people. So watching, that peer support piece, all of those pieces. So for me, it's always about a day-to-day thing, right? If I can help one person, I've done something, and continue to empower and advocate those people to help others. It's like a seed. So you just plant it and it keeps growing and it keeps spreading. And that's what kind of keeps me going.
Nice. And as a social worker to another social worker, how do you maintain hope and resilience while working in a field often challenged by systemic barriers?
I like that question. So you clearly you've seen the TAIBU logo. You know what it looks like.
Yeah.
So you know the two hands that are right next to each
Yes.
other? That's how I knew that this was my space. So again, my grandmother used to always laugh and tell us whenever we fought as kids, she would say, have you ever seen somebody trying to wash one hand, like with one hand? And we'd laugh and be like, oh, you're not making any sense. And we would, we'd go away. But her whole point was that she would always say it's one hand to wash the other. So you can't do anything without two hands, right? I can't do this work without two hands, without more help, without all the people that are a part of it. And I think for me, that's what resonates with me all the time. It's the community that shows up. It's the other people that I work with. It's the staff that works with me. It's, my family that's around me. All of the supports that we're creating for community, having all of those as well to do the job, that's what keeps me coming back. It's one hand to wash the other. So I know I can't do this by myself. And I have people that are just as passionate, just as motivated, if not more motivated than I am. So I'm like, if they can still do it, I can absolutely keep going.
You know what? I think I'm going to, now every time I'm going to look at the TAIBU logo,
That's what you
it's going
see?
to be different for me.
Yeah, it was funny for me when I accepted the position and then I looked at the logo. I thought, oh yeah, this makes sense. Always,
Right.
yeah, absolutely.
Wow, thank you.
You're welcome.
My final question.
Okay.
What does be in good health mean to you?
Be in good health means to me to have balance, to be able to be present in every situation that I'm in. So if I'm here or I'm working, to be completely in there. When I'm at home, be completely present there. Because to me, if you're in good health, you're balanced. You've given a little bit of yourself in every area that's possible. You're not teetering too much on work or teetering too much on relaxation. Being in good health is knowing, is being balanced. And if you're not balanced, knowing when you're out of balance. Well, that's what it is for me.
Thank you very much.
Thank you.
Always a pleasure, Racquel.
Absolutely.
Appreciate the conversation. I also appreciate the work that you do.
Thank you.
I'm honored to have been working with you, to continue to work with you. This brings to our conclusion of this conversation. Please thank Racquel Hamlet on my behalf, and I hope this conversation was helpful in understanding how systemic barriers impact on the mental health of communities, particularly the Black community. But there are also some initiatives that can really address these issues, just like the Toronto Community Crisis Response Service and other initiatives that we at TAIBU provide that, but are also provided across the city, across the province. Thank you.